One, action.
Okay. Good morning. I'm Larissa Maley. I'm the clinical program manager over at the Addictions and Substance Abuse Programs. I'm also a postdoctoral specialization in trauma psychology or interventions to treat trauma disorders. So I'm very excited to present this to you guys today. I think this is really an important area, particularly with working with substance abusing populations, because we know that there is such a overlap between individuals who develop a substance use disorder and early experiences of trauma or some experience of trauma in their life, that they tend to go hand in hand. So my goal today is to introduce a brief summary of what trauma is, so you can walk away with that definition, and then what are the different conditions that can arise from it, as well as what can arise from it that is not a disorder. So let's get started talking about trauma and trauma symptoms design. So the first thing I want to introduce is just this difference between stress and trauma, because they are different things, and oftentimes they get confused in our society. And a lot of the circles within we run, we throw the word trauma around a lot, and so it tends to lose its meaning. I can't tell you how many meetings I've been to where people have said things like, "Oh, that was so traumatic," and they were talking about, a bad haircut that they got. Or I think I have PTSD from that last meeting. I've heard lots of different phrases like that that tend to sort of cloud the definition of what trauma is. So I just wanted to give that explanation. So the first thing is for us to start with stress. What is stress? Well, most of us think that we have too much stress and we definitely need to have less, or that ideally we should have no stress. We want a stress-free life. And what this stress curve tells us is that's not really the case, that there's actually an optimal level of stress, and that we need a certain level of stress to be able to perform, to be able to develop this thing that many of you have probably heard of called resiliency. So if you can see on the green, this is where we have too little stress. So our performance is actually quite low. So if we don't care about, let's say, going to work in the morning and that meeting that we have or that presentation that we have to give, if we don't have any stress about it, then we're probably not going to prepare. We may show up late. We might forget about it altogether. And so our performance is not going to be very high. So we want to have actually an optimal level of stress where we care just enough to be activated, to do what we need to do and to do it well, and to also be able to understand that we can tolerate that distress. So exercise is a good example. This happens the same way. So when we first, if we don't exercise at all, right, we tend to be pretty out of shape and can't lift much of anything and might get winded coming up the stairs. Once we start exercising, we might be sore for a while, it can be pretty difficult, but eventually we build up a tolerance where we're able to maintain that exercise plan without being too sore, without too much distress, and then we can handle events of day-to-day life like running up the stairs or lifting a heavy weight and doing it without too much effort. So that's what we're talking about here with psychological stress. We're building those muscles or that same kind of resiliency. So we want to be in that yellow quadrant. Now, we do hit a tipping point. So if we have too much stress or too much stress that goes on too long, or the stress exhausts our internal resources or external supports, our ability to manage, then we go into what's called exhaustion and breakdown, which is the orange and the yellow. So that's essentially where we're overloaded in our capacity to manage whatever that stressor is. And then if it continues, then we will end up going into breakdown and burnout, and our performance also decreases. So too little, not great, and too much, not great. But there is an optimal level that we're trying to hit, and that will come into play when we talk about trauma here in a minute. So what is stress? Well, it's something that happens across the course of life, and it's necessary for resilience and functionality. Human beings' response to stress is going to vary. It depends on how intense the stressor is, our own personal history of managing stressors, our coping style or our resilient style, how much of it do we have, how many skills do we have, what supports are in our life, both internal and external. But at the end of the day, as human beings, because life is stressful, always has been, always will be, we have an innate ability to adapt and cope with stress. So typically, especially with acute events, one-time events, they tend to be short in duration, relatively high intensity. We can manage these pretty well, right? A car gets stolen or a pipe breaks in your house and your basement gets flooded. It's pretty stressful, but we have the ability to manage it. And why we have that ability, this innate ability, is called the alarm response. And what that means is that our system physiologically and psychologically will activate, and I'm going to show you what that looks like in a moment. So we have a whole slew of psychophysiological changes that happen in the short term to arm us to be able to adapt to that stressor, to mitigate it, and then return to our baseline. Now, what happens with chronic stress, this is a little bit different. This is a repeated event that, depending on the level of intensity, can be much more difficult to manage and can start to lead to that burnout red zone. So ongoing marital discord, living with a chronic illness, or caretaking responsibilities are particularly bad in that regard, and that these are sort of chronic stressors. They don't let up, and any human being is going to be taxed and exhaust their ability to cope and manage that. And so then that can lead to the same alarm system activation, the same psychophysiological changes, but without more support or without that stressor being mitigated in some way, you're not really going to be able to shift back to your baseline. And so that can lead to a whole host of what we know as chronic stress conditions. So a lot of different physical ailments or psychological ailments, particularly depression or anxiety, are linked to this phenomenon. So this is that alarm system. It's called the adaptation model, and this is what our bodies and our brains do when a stressor occurs. This blue line is our baseline. That's our homeostatic line of functioning. So that's how our body, our brain, and our ability to function in the world kind of is, all things considered equal, all things going well, right? Now, if a stressor occurs, and this can be both threatening or it can be exciting, so this could include a wedding, this could include the birth of a child, but a stressor happens, you have an initial dip in how you're functioning, and if you can think back to a recent stressor that might have happened to you, you might recall this, like maybe that immediately right after, you might have felt a little more panicky, your appetite might have shifted, you might have been a little cloudy in your thinking, or you might not have slept so well that night. But then over the next couple of days or couple of hours, depending on what the stressor was, your body goes into this alarm response and it changes to accommodate for that stressor. So your functioning actually goes up. This is where your body floods with cortisol and adrenaline and gets you ready to take on whatever that stressor is. So you actually end up performing, recall this for those of us who were in school, and if you ever had to study for a really big exam, even if you pulled an all-nighter without getting any sleep, you might have felt like, man, I could just focus, I could get it done, I was ready to go, and that's this alarm system going on, that you're actually mobilizing to manage the issue. And this forms resiliency and resistance. And this is that building that muscle that over time is happening. Now, if the stressor continues, or if you don't have the external or the internal resources to be able to manage that continuing stressor, then we're going to see, again, a drop in functioning. So some kind of exhaustion is going to occur. And that would be where I haven't slept for several days, and now exhaustion is setting in, and I'm not functioning very well, at which time I either have to increase my coping, my self-care, work to decrease that stressor and return to baseline, or it's going to wind up in some kind of chronic illness, and eventually what we know, the science says, is premature death, because chronic stress is really, really destructive to the body. So this is where that resiliency piece comes in. So how do we deal with stress? Well, typically most people recover very quickly following an acute event. Nothing is really needed. We have this innate ability to manage it. Chronic events, however, usually require more intervention, and those interventions look very similar to how we would treat whatever the symptoms are. So that could be maybe some psychopharm, like an antidepressant for a period of time, seeing a psychotherapist, making lifestyle changes, reaching out to friends and family for more support. But essentially, most human beings have an innate ability to adapt and accommodate, even to chronic stress, but that does vary by the intensity and the frequency of what it is. Now, let's talk about trauma. How is trauma different? The DSM defines trauma as actual or threatened death, serious injury, or sexual violation resulting from one or more of the following. So that means either directly experiencing it yourself, so the actual or threatened death, serious injury, or sexual violation, so the assault or a physical or sexual assault, domestic violence, a severe car accident, witnessing the event, so being in the room when it happens or in the near vicinity when it happens and witnessing it happen, learning of it through a close family member with vivid details. This happens fairly rarely. This is not the same as a mother finding out that her child was killed in a car accident. That is a terrible stressor. That is a very difficult thing for a mother to find out. However, if the mother was to be given the crime scene photos from the car accident so that she had the vivid details, that would qualify, because her mind would be able to put together what happened with those images. So it would be very similar to as if she was witnessing the event in person. So that's what that one is describing. And then the last one is experiencing repeated or extreme exposure to details of traumatic events. So this is not necessarily watching the news. What this is to capture people like detectives, like military personnel, individuals who have to look at crime scene footage or video repeatedly as part of their job. So they can also experience that as traumatic, particularly when it's repeated or extreme in nature. So these are the different things that qualify trauma. And what I'd like to encourage you to think about trauma as a different process from how we naturally accommodate stressful situations. So it's experienced as sort of outside the realm of what our short-term response and recovery can typically manage with that quick return to baseline. So if you think about this from an evolutionary perspective, as our brains were developing and evolving into Homo sapiens, we experienced a lot of chronic stressors, a lot of not knowing where your next meal was going to come from, a lot of kind of just chronic stress exposure. So we developed an innate ability to manage that. Now, the bigger things that would happen much less frequently. So our brain would not necessarily develop an automatic response to be able to accommodate that information. So natural disasters might happen once in a generation. Having a severe injury or death within the group might not happen that often. And then interpersonal violence. And this is one that I always question people to think about. This probably does happen quite frequently, but why, from an evolutionary perspective, would it be so difficult for us to accommodate it and return to baseline quickly? Now, a lot of the theory out there would suggest that one of the reasons that interpersonal violence is so destructive is because we are social creatures, and we developed within tight-knit social circles. So our brain is hardwired to trust the people around us. Our brain is hardwired to trust our caregivers. We need them to be able to develop into adulthood and take care of ourselves. So when a caregiver or with someone in close to us violates us physically or sexually, that is such a difficult thing for our brain to make sense of, because it short circuits that natural ability to just trust the people around us. So we think that that's a piece of why those things are so much more difficult. So if we think about it on a continuum, trauma indicates that it is a specific or extreme type of stressful event. So in other words, traumatic events are stressful events, but stressful events are not traumatic events. So they sort of exist on this continuum, right? That we can objectively identify specific events as being traumas. And that's really important as clinicians that we understand that difference, because people will come into our offices and they will be describing things that are very stressful, very difficult. A loved one that they were very close to passed away, that they had their kid taken away by CYFD, or maybe they were recently evicted. These are very difficult events, and we would want to treat them in a similar manner. But these are not traumas. They are not going to override the system and cause the cascade of things that will happen as a result of a trauma. So we want to always make sure that we are diagnosing correctly and matching it with the right intervention. So that's why it's important for you to understand that trauma is an objectively defined thing. It is a specific type of stressful event. So we can break traumas into different categories. A shock trauma, similar to an acute stressful event, is a single event. It's short in duration and it's high in intensity. So being mugged in the parking lot, or a sexual assault by a stranger would be a shock trauma. Single event, short in duration, high in intensity. Strain events are multiple events that are long in duration, and they tend to be less in intensity. And the reason why they're less in intensity isn't because the event is in some way like less difficult, but it's because we learn for it to be predictable. We learn to expect it. So the first time your father hits you, that's probably pretty intense, and you might experience it the way you would experience a shock trauma. But the 20th time he hits you, it's going to be less in intensity, just because you have now grown to expect it. So when we think about domestic violence, we think about child abuse, we're thinking about those strain traumas, multiple events, longer in duration. And then strain traumas can be broken into two separate categories: chronic, so multiple events over a long period of time. So domestic violence would fit into that category. Or complex, and that is multiple events in childhood specifically caused at the hands of a caretaker. So complex strain traumas tend to have the most devastating effects, because they happen in childhood and they happen again at the hands of the people who are meant to take care of us. So that's important to kind of know that difference. And the same thing, understanding when trauma happens. So the nature and chronicity will impact somebody's potential outcome. Adult events tend to be less detrimental. And I'll go over the different variables that come into play with someone's prognosis. But in general, adult events tend to be less detrimental in terms of how they impact the system. However, if they are chronic adult events, so chronic traumatization, chronic assaults, chronic domestic violence, without treatment, it will result in similar disease states, so a lot of negative health outcomes. Childhood events, particularly ongoing traumatization, are showing that they have the most significant long-lasting impacts, particularly on neurodevelopment. And one of the studies that I'm sure you're all familiar with is the ACE study, and they were able to show that these adverse childhood experiences, with a whole host of different traumas included in those adverse childhood experiences, result in a cascade of neurodevelopmental impact. So essentially, early traumatization changes how your brain is functioning. And over time, that changes how you are able to interact with the world, how you are able to regulate your emotions, how you're able to think and concentrate. And if you cannot do those things effectively, you're most likely not going to do well in school. You're most likely not going to do well with peer relationships. You're most likely to lead to adopting a whole host of risky behaviors, or behaviors that at the very minimum do not lead to good self-care. And then that leads to high likelihood of disease onset, social problems, involvement in criminality, and then we see early death. So are those early childhood traumas devastating? And they can be pretty devastating on whole communities. So when one interesting thing from the study was able to show that intergenerational transmission of trauma, that when communities or families experience early childhood trauma and they don't get the help that they need, then their development is disrupted. They go on to translate a lot of those same behaviors and beliefs to their children. So then their children have now very similar prognosis or patterns to what their parents had, even if they didn't experience the same trauma. So how do we respond to it? Well, that varies by the type of trauma that it is, if it's strain or shock, if it's interpersonal versus disaster, how close we are to it. So if it's us versus we saw it versus we were looking at it on videotape. If we had previous traumas, and this is bidirectional. So previous trauma could actually help us to develop resiliency. So we might be more equipped to handle a later trauma and we might recover from it faster. Or previous trauma could wear down our resistance, and so we are more vulnerable when that next trauma comes along. So our resource reservoir is depleted. So then we might have a more negative outcome. It depends on the relationship to the abuser or the perpetrator. So is this somebody that we know or don't know? What coping skills we have. So what is our strengths, our internal resources, and then what are our vulnerabilities? What are the things that aren't so strong or aren't bolstered up as much? The response of our support system is particularly predictive. And if you think about this, with particularly sexual assault survivors, which we know to be one of the highest linked to later disorder is sexual assault. How does the support system respond to that trauma? As a society, we tend to blame the victim. We tend to say, well, why were you at that bar drinking at night by yourself? Well, why were you dressed that way? It was your fault. You must have been asking for it. Those things can be very devastating to being able to recover effectively from trauma. So that's an important factor to consider, because you as the clinician, when you're getting these people in, you might have to course correct some of the things that went wrong with their support system immediately after the trauma. Or another factor to consider is because certain traumas, particularly sexual assaults, are very stigmatized. And so not all survivors will let people know that they've happened. They might keep it secret or they might hide it. And so they don't get the support that they need in the aftermath. The other thing to consider is the level of stress at the time that the trauma occurs. So are they already in that dip? Are they already in that red zone, just trying to cope with the stressors going on when the trauma happens? And when you think about a lot of the patients that we work with, this is really an important contextual variable. A lot of the folks that I work with at ASAP have very limited resources. They struggle with chronic homelessness. They tend to not have adequate transportation or childcare or ability to take care of basic needs. And when you're in that situation, I mean, life is very, very stressful. And then if a trauma was to occur while you're coping with all of those stressors, it's more likely to result in some kind of disorder. The other important variable is the perception of the event. So how does the person actually believe about themselves and others as a result of the trauma? So are they blaming themselves for it, depending on how the support system responds? Or are they seeing this as, well, because of previous perceptions I had, this makes perfect sense. Like, of course, all people are bad. Nothing good ever happens to me. That perception or those cognitive structures are going to impact how they then recover from that event. So let's put this into some numbers. I think that on average, when we look at meta-analyses, approximately 77%, but upwards of 87% of all adults have or will experience at least one trauma in their life. So the vast majority of human beings will experience at least one over the course of their life. Now, of that percentage, that 77%, the vast majority, about 70%, will actually recover no intervention, that they need time and social support, and they will get this thing called natural recovery. So good news. The majority of people will experience trauma symptoms immediately following it, but that is that adaptive response. That is not a disorder, and that's why there is a time distinction with diagnosing PTSD. We do not diagnose PTSD for at least a month after the event has occurred. That's important because everybody who experiences a trauma is going to experience a lot of those symptoms immediately afterward. They're going to get a drop in homeostasis, but eventually a restoration and adaptation and accommodation of that event in a healthy, natural way. So this exact same thing will happen with trauma. How we respond to stress, how we respond to trauma. We will get that natural recovery. If we don't, it might lead to some symptoms. So this is important to understand. What is going on? Why are we, the majority of us, recovering naturally? Well, I like this quote by Ernest Hemingway: "The world breaks everyone, and afterwards many are strong at the broken places." And I think that's really clear in terms of defining, as human beings, we can overcome tremendous adversity. We, with a little bit of support, can accommodate almost anything that happens to us. And it helps us to grow, and it makes us stronger. And we see that even at the biological level. How do we build muscle? Well, we first have to tear it. And then when it heals, that's when it grows back stronger. The same thing happens when we break a bone. The strongest part of the bone is at the break point, because that's where the body rushes all of the additional minerals and calcium to restore that broken point. So for a lot of people, post-traumatic growth is actually a positive experience. It is a cognitive shift that occurs after a traumatic event, and this can occur either through natural recovery or following treatment. But it's where they're able to sort of make constructive meaning out of the event. So they're able to say things such as, the event gave me the opportunity to develop more strengths, to be able to cope with life better. I know I can handle things better now. Or the event renewed my belief that it's important to pay attention to what's happening right now, that the present is a gift, and I need to be there for other people because life is hard, right? So that kind of mindset. And I think particularly for clinicians, when we're working with a lot of traumatized people, we can pick up on some of that, and we can start to think the world is a dark and scary place, especially when we hear a lot of those stories. But the nice thing about treating trauma survivors is getting to see them recover and get this post-traumatic growth, because then we get it as well. And I know for me personally, every time I work with a trauma survivor, it is just proof in the resilient capacity of humans. It is such a rewarding thing to be able to see people recover from these events and fully restored and actually stronger than they were before. So now let's start to talk a little bit about the common reactions that all people have. So of everyone who is exposed to a traumatic event, these are the things that will occur. Short term, you will have an acute response, and that is, I'm going to list all of the sort of symptoms that can happen. This is not indicative of later disorder or functional impairment. So unless seeing them completely drop out for that first month and are unable to function at all, it is probably a natural response. It is that acute response and that drop in homeostasis, and we just need to be a support for them and keep reminding them that they can handle it, that it will get better. Now, what happens when it's around? That's when we're now looking at a disordered response. So all of the trauma disorders that we're going to talk about here in a little bit, those are disordered responses, but those are because the symptoms, the natural reaction to the trauma got stuck on. And that only happens with about 3% of individuals. So let's talk about what those are. Well, it can be neurological effects. So that can essentially how the brain is functioning, and over time, how the brain structure actually looks. So what happens is your autonomic nervous system or your limbic system gets activated, that freeze response gets activated, and it gets attached to a whole host of different variables that occurred at the time of the trauma that later become triggers. And so when you're either immediately after the event or you're thinking about the event, you're experiencing that same autonomic nervous system arousal where a whole host of hormones get activated to cause all kinds of physical and psychological changes. So that's the HPA axis, which includes the hypothalamus, the pituitary, and the amygdala. And that's our fight, flight, freeze response. In chronic conditions, what we're going to talk about in a little bit, that HPA axis overactivation can actually cause neuroendocrine system changes. So you will have significant changes in the hormones that are being produced in the endocrine system, and structural changes in the brain. So the brain physically will start to change if the HPA axis is active. And that alarms all of these, this cascade of events. So we'll have saliva flow decrease, blood vessels will constrict. Thank you. It's allergy season. Your heart rate harder. You might actually change. Stomach is digesting. You might become more tense or get some more muscle rigidity. Pupils will dilate, increase in breathing or rapid breathing. And then we'll have changes in blood pressure and blood vessel dilation. So makes sense that it would cause all kinds of effects as well. So that could be experiencing pain or different somatic complaints, sleep disturbances, intense fatigue, can have things like forgetfulness or confusion, significant concentration issues, things like sexual numbing or complete decreases in sexual interest, that HPA axis response. It can also problems, heart problems, respiratory problems, and some dermatological conditions can be exacerbated. People that might even have autonomic conditions, they can get this immediately after a trauma. It will also cause emotional effects. So you can either sort of chunk it into two categories, and people tend to fluctuate between the two. Intense negative emotion, so fear, anger, anxiety, sadness, powerlessness, guilt, shame, or feeling nothing, feeling numb with just a range of affect and feeling detached and disconnected. And a lot of people tend to flip between those two extremes. And then that can cause psychological effects. So because of all the emotions that are going on and because of the tendency to believe our emotions go up, we can have all kinds of different distortions start to develop where we distrust others and ourselves. We might feel a decreased irrational guilt about the future, feeling all kinds of shame and stigma about the trauma, and then a particular estimation and preoccupation with safety. So where before I felt safe going to the grocery store or I felt safe driving through my neighborhood, now I don't. Now I don't feel safe anywhere. And then behaviorally, we'll see things like increase in tearfulness or crying, agitation, even an increase in irritability and aggression. Or we can see an increase in passiveness, so just retreating. I don't stand up to anybody now. I don't even talk to anybody if I can go that route. Diminished interest in activities. Risky or impulsive behaviors can come on, and what we think is going on there is because the autonomic nervous system is so out of whack, people are feeling like they're riding a roller coaster. They want to match inside experience with their outside experience. So riding on a motorcycle 100 miles an hour down the highway is going to match that internal experience. So that's why we can oftentimes see an increase in those kinds of behaviors right after trauma. Increased use of substances is extremely common. It's probably one of the most common behavioral effects that we see. And then phobic reactions, so being phobic about a specific area or specific thing that is in some way connected to the trauma. And then this will, of course, lead to a whole host of social effects. So isolating, detaching from others, overworking, feeling like your relationship is strained, neglecting responsibility. So that's all the stuff that will happen within the first month to 2 months right after trauma for almost everybody. And they might not get all of those symptoms, and they might not get them at super intense levels that will really affect their functioning. Most everyone will get a number of those symptoms, and that is a normal part of the reaction to trauma. Now, what happens for people that get stuck with that stuff and leads to trauma disorders? They end up with things like or ASD, acute stress disorder, or mood disorders like depression and anxiety, obsessive compulsive disorders, a whole host of sleep disorders, substance use disorders, or other addictive disorders. And then this thing that is not in DSM-5, but we believe will be at some point soon, is a phenomenon called complex trauma or complex PTSD, which is a result of the childhood trauma at the hands of a caretaker. So that complex trauma in childhood can lead to not just all the stuff we listed, but also dysfunction in interpersonal functioning, identity disturbance, mood regulation, all kinds of things that tend to look a little bit like borderline personality disorder. And so this, I think, is an important conceptualization to have on hand when you're trying to differentiate. There's early childhood trauma at the hands of a caretaker, and the person sitting in front of me looks a lot like BPD. It may be BPD, but it may also be this thing called complex trauma. And they're going to have different treatments and respond to treatment differently. So that's an important thing to just kind of keep in the back of your head. Now, if we look at prevalence rates, I think this is interesting because the majority of, I guess, the greater culture tends to believe that if you have trauma, you're going to have PTSD. And that's not the case. That actually what we see is more likely outcome from trauma exposure are anxiety disorders and substance use disorders. Anxiety disorders, 18%. So much higher numbers are going to end up with an anxiety disorder. And you can see the breakdown percentages there. The majority, some kind of social anxiety or specific phobia. The next highest percentage is a substance use disorder. So you might have a lot of people in your office that are there for substance use disorder, but what might be driving that substance use disorder, it's not PTSD, but it is trauma exposure. It's the trauma exposure that is driving the use pattern. And now they've become dependent, and now we have a legitimate substance use disorder. So you can see that breakdown there. And then the next highest percentage are depressive disorders like major depressive disorder and persistent depressive disorder. And the lowest percentage, only about 3.5% in aggregate, is PTSD. So it looks like this, right? All of these conditions have symptom overlap, that they share similarities in their symptom profile. So when we're working with somebody and we know that there is trauma in their history and we think that the trauma is affecting their current life, then we want to be thinking about this Venn diagram. Where is the majority of their symptoms being accounted for? You can have a condition in each of these quadrants, but I think it's most helpful in terms of treatment planning for us to try to be as specific as we can. Not everybody who has trauma has PTSD. They much more likely would have one of the anxiety disorders or a substance use disorder. So how do we assess it? Well, first, they have to have a trauma, and that's why I kind of belabored the point what traumas are. It's not grief, it's not stressors, it is not subjective. It is not them telling you that it was traumatic. It is you making the determination, does this meet the qualification for trauma as we know it? Also, symptoms have to be currently present and their functionality is impaired. This is really important. I've worked with a lot of clinicians who will say, well, I think they have PTSD because they had this horrible trauma happen in their childhood. They're just suppressing the symptoms. I just don't think that they're presenting with the symptoms, but they must have it because they had the trauma in their childhood. That is really incorrect. So we have to be looking, they definitely had trauma and they currently have symptoms where functionality is present. So no past symptoms and no assumption of dysfunction, because we know the vast majority of people will recover on their own, that they will get natural recovery. So we want to give them that time and that space, and we don't want to be making assumptions that just because trauma was there, there's going to be disorder. And the duration of the symptoms have to be longer than 1 month. So we use reliable screeners. These are some for anxiety conditions, depressive conditions, substance use conditions, And I think some of you might have been there when I gave the screener lecture, so I'm not going to go into these. So for PTSD, I recommend that everybody use the PC-PTSD for everyone that they work with. This is a 4-item brief screener. If they pop positive, then you can give them the PCL5. The PCL5 is never intended to be used for diagnosis. It is meant to be used if we're pretty sure that PTSD is the issue, because a lot of people with depression and anxiety will give you a positive score on the PCL5. So that's why it's a good rule of thumb. We want to use an initial screener before we give them the checklist. And then for those of you that would like additional training, you can get something called the CAPS, which is it's the gold standard intervention. It's a clinical interview that can be administered by master's level and up clinicians. And it's very effective for helping to diagnose PTSD when it's questionable, when you're not sure if that's what you're looking at. So again, if we go back to some of these prevalence rates, we can break it down into smaller units. So you can see men tend to have a lower percentage of PTSD, 2% to 4%, and women a higher percentage, 3 to 10%. And why we think that is that the majority of PTSD, or I should say the trauma that is most associated with PTSD, is sexual assault. And then childhood sexual abuse is the strongest predictor of lifetime PTSD. So those two traumas, we think tend to be affecting women at larger rates. PTSD is the highest comorbidity of any psychiatric condition. So if you're thinking PTSD is on the profile, we also want to make sure that we're looking for anything else that might be causing problems. 92% of people with PTSD have a secondary anxiety or mood condition. 69% MDD, 23% PDD, 15% a specific phobia, 31% lifetime alcohol or drug use. So that's an important thing. Now, when we're talking specifically about PTSD, and I know we don't have a ton of time to go through all of this, but I just want to explain all that, every slide that I showed you that was the list of the common reactions to trauma, when they get stuck on, that looks exactly like PTSD. So if you think about it as it is after trauma, an anxiety stress reaction that is stuck on. So you can break them into what are called clusters, all of those symptoms. And these clusters interact with each other like a cycle or like links in a chain. So for instance, when we were talking about that fight, flight, freeze response, that's that autonomic nervous system, or what we're labeling as hyperarousal. So that means that their nervous system is in overdrive. And that's going to cause things like hypervigilance, sleep problems, and overactive startle response. The re-experiencing is the trauma intruding in their current life. So it's coming in the forms of intrusive memories, in flashbacks, and what are called emotion and body memories, where it is part of the memory that's sort of broken apart. So people could be sitting there and all of a sudden they feel the fear that they felt at the time of the trauma, but it's disconnected from the memory itself. They just feel overwhelming fear. Or they could be sitting there and all of a sudden their body tenses up and their body responds the way it did at the time of the trauma. That's actually a form of memory that's intruding in current life. So that's part of the re-experiencing cluster. And then, because the hyperarousal and the re-experiencing is so disruptive, it can also cause a shift in how we're thinking and how we're feeling. So you get a shift in beliefs from, I used to feel safe, to now I don't feel safe anywhere. I used to be able to trust people, now I can't trust anyone. People I used to think were relatively good, now I think everybody's just garbage and they're out to get you. And so that comes with it what looks a lot like a light depression. So low mood, pessimism, feeling like there's no point, there's no future, kind of hopelessness about what's to come. Now, because these top three clusters are so painful and difficult to live with, we then get a pattern of avoidance. So that's where people are avoiding all the people, places, and things, every trigger that is associated with the trauma. They don't want to talk about it. They don't want to think about it. They're spending all of their time isolating, overworking, using substances, anything they can to block out the trauma or the symptoms that come along with thinking about the trauma. Now, because this is a link in a chain, how we treat this is pretty straightforward. We treat it by helping people to, instead of avoid, to start to approach. Because when they give themselves permission to think about it, to process it, to go into that trauma in a structured and safe way, their nervous system will start to regulate. They will start to make meaning out of the event. Their cognitions will start to shift back to a more realistic range, and they will get natural recovery. And that's exactly what happens to people who don't develop PTSD. They don't avoid. That's the one link in the chain that's missing in terms of what determines why someone ends up with PTSD and why someone ends up with natural recovery. So what we're doing with treating PTSD is just helping them to get on that natural recovery pathway by decreasing how much they're avoiding. And all of the gold standard treatments that go along with it, evidence-based treatments, which I'm not going to go into, are structured to help people do that exact thing. So exposure therapy is techniques that help them actually start to approach the feared object, situation, or memory in a systematic manner. And cognitive therapy is helping them to approach the thoughts, the memories, the beliefs that have formed about that trauma. So we can think of it as a top-down versus bottom-up situation where the cognitive approach is going through the brain, the thoughts first, the brain first, into the body, and saying, if I can change how I'm thinking, I'm then going to change the behaviors that I'm doing in the world. The bottom-up approach, which would be more of the exposure approach, is where we're going the opposite direction. We're starting with the body and going into the brain. So we're saying, I'm going to change the behaviors that I'm doing. I'm going to start repeatedly exposing myself to these feared situations and stimuli, and then that's going to change my thinking. So they both get us to the same point, and they are both equally effective, but they take two different directions. Commonalities across them, and this is why I think it's really, really important that you get specific training in the evidence-based interventions for PTSD, is we always want to make sure that the patients feel safe, that they feel like they have a choice in making the decision for treatment, and that they have all the education that we have. They are experts in their PTSD. They know everything about it. They know what they're getting themselves into, because we want them to be empowered. We want them to start to approach instead of avoid. And that is not going to happen if they're coming at it purely from a place of fear, if they feel forced, if they feel like they don't have choice in the matter. And then the other big piece is that the natural recovery is allowing them to go through a grief process and actually make new meaning and get that post-traumatic growth. So these are the recommended treatments for PTSD: cognitive processing therapy, which comes in both group and individual; prolonged exposure therapy, which is individual only at the time; and EMDR, which is individual only. And the actual gold standard interventions are only CPT and PE. EMDR does not have as good evidence base behind it. So if you have a choice, I would absolutely encourage you to do treatment of either CPT or PE. And then there is some evidence that acceptance and commitment therapy can be helpful, but again, it is not one of the gold standards. And then for major depressive disorder, which could be a trauma disorder, interpersonal psychotherapy for depression, cognitive behavioral therapy, short-term psychodynamic psychotherapy, and ACT for depression. And then anxiety disorders, interpersonal psychotherapy, IPTA, cognitive behavioral therapy, and ACT for anxiety. So just one quick note I want to leave you with is we oftentimes get very scared in working with substance abusing populations that if we try to treat their PTSD, if we try to work with them on their trauma, we're going to open up Pandora's box and they're going to relapse, or they're going to use more, or something terrible is going to happen. That has not been weighed out in the evidence. Typically, people engaging in these very intensive, difficult treatments, prolonged exposure and cognitive processing therapy, do not relapse if they have established sobriety or do not use more. That it actually helps them to get relief from what is causing the drinking or the drug using, and they can get better. So it's endorsed as a model, as model programs, both of those conditions by SAMHSA. And they are very much encouraging you to use those as treatment interventions along with your substance use treatment. So that's all I got. Does anyone want to stay on for a question or two?